Hi, my name's Aaron MacDonald. I'm an anatomy lecturer at La Trobe University, and today we'll be looking at the radioulnar joints. As I mentioned, we'll be looking at radioulnar joints, so there's more than one joint, more than one radioulnar joint, and here we have a superior radioulnar joint, which is also considered a proximal radioulnar joint, and an inferior or distal radioulnar joint between obviously our radius here and our ulna here. Histologically, both of our joints are considered to be synovial joints, again having synovial membrane, synovial fluid, and a large range of movement. Functionally, the shape of both of our radioulnar joints are pivot, and movements, we're probably all aware of the movements occurring at our radioulnar joints are supination and pronation. And you'll be aware that the radius is moving over the ulna, so any type of movement for supination and pronation results in the radius moving around the stable ulna. And for any type of movement at the proximal radioulnar joint, we must also have a subsequent movement at the distal radioulnar joint. So movements of supination and pronation occur at both joints at once. Looking at the proximal radioulnar joint, we have the head of the radius is articulating with the radial notch of ulna. So looking at our diagram over here we have a superior view looking down onto, this is the head of the radius, and this is what we call the radial notch of ulna. So looking again at this view here, we have the radius and we have a little notch in here called the radial notch of ulna, which is quite descriptive. I guess it's quite an easy thing to remember. It's the notch in which the radius articulates. To hold the head of the radius in position, we have a structure called the annular ligament. Now this is a fibrocartilage structure, so again looking at our superior view, we have this annular ligament wrapping around the head of the radius, and this holds the head of the radius in position and enabling us to form the radioulnar joint. On the inside, it says here the internal surface is covered with cartilage, so the inner surface of the annular ligament is a cartilaginous makeup, allowing a free range of movement for supination and pronation. We have a little ligament here called the quadrate ligament, and that is there to assist in holding the neck or the radius in its position with the ulna. In your text you may also find that they name an oblique ligament. This ligament is functionally insignificant. It's considered to be functionally insignificant these days. People have cut the oblique ligament with no detrimental effects on movement. And again, if you remember back in the elbow joint film clip, you'll notice that the proximal radioulnar joint also shares a joint capsule with the elbow joint. And here, looking at the joint capsule again, which is encasing our proximal radioulnar joint. In our distal radioulnar joint, so here we have the distal radius and what we call the head of the ulna. So in our proximal radioulnar joint was the head of the radius, which was up here proximally, articulating with the ulna. In the distal radioulnar joint we have the radius, and the head of the ulna is articulating with the ulnar notch of the radius. So in here we'll have a notch in the radius called the ulnar notch, where the head of the ulna articulates. Just distally, or forming the base of this distal radioulnar joint, we have an articular disc or triangular ligament, and as you can see it forms a triangular shape. It's between the apex of this triangular ligament is the styloid process of the ulna, and the base is travelling along the ulnar notch of the radius. And you'll see it's mentioned it's biconcave to articulate with the head of the ulna proximally. So it'll articulate with the head of the ulna. So this surface here will be covered in cartilage and enabling the head of the ulna to articulate. And also you may imagine that here distally we have carpal bones or bones of the wrist, and the articular disc also articulates with these bones as well. Anteriorly or on the palmar surface and posteriorly or on the dorsal surface we have ligaments, obviously quite descriptive ligaments called the palmar radioulnar ligament and the dorsal radioulnar ligament. So looking again at the distal radioulnar joint, we see our triangular ligament or our articular disc, and this is a distal view, an inferior view of our distal radioulnar joint. And we have here our dorsal radioulnar ligament, obviously between the radius and the ulna, and our ventral or palmar radioulnar ligament, a thickening of our articular disc anteriorly and posteriorly. In this view here we see the axis of movement for our radioulnar joints, or supination and pronation. So you can see the axis is running between the head of the radius and through to the head of the ulna. So as mentioned, the radius moves over the stable ulna. So during supination, our axis is from the head of the radius to the head of the ulna, and during pronation, again through the head of the radius to the head of the ulna. And we can see that the radius has moved over the ulna. Just looking at this figure here from Moran Daly, on the left here, we have again our ulna and our radius, and in addition to the annular ligament and our dorsal and palmar radioulnar ligaments along our articular disc, we also have connective tissue between the radius and ulna, and this is what we call the interosseous membrane. So it's a membrane between the bones, so between osseous is bones, so our interosseous membrane. And this is there to stabilise both joints, both our proximal and our distal radioulnar joints, and as it says, it's taut in mid-prone. Obviously we need muscles to produce movements at our radioulnar joints, and for pronation we have a couple of main muscles involved, which is pronator teres. So we can see from our medial epicondyle running from the medial side obviously to the lateral mid-shaft of the radius, we have our pronator teres. And distally we have this four-sided structure, so quadratus, and if it contracts it will produce pronation, so we call this pronator quadratus. And as you may notice, a muscle must insert onto the radius to be able to produce the movements of supination or pronation. Muscles for supination, we have the supinator, which is very descriptive, as we can see, running from the lateral aspect of our lateral epicondyle, lateral ulna, and wrapping around the radius. So if this muscle contracted, it would pull my thumb back out and produce supination. When looking at the biceps brachii, you see that the attachment is onto the radius, so any muscle attaching to the radius has a chance of producing supination or pronation, and so we see that the biceps brachii are attaching to the radial tuberosity, and in the following clip you'll see that we can actually feel or determine the movement that is being produced by biceps brachii and determine whether it is supination or pronation. As with a lot of anatomy, I like to use my cheat sheet as much as possible. So when I'm trying to remember the action of the biceps brachii, whether it is pronation or supination, all I have to do is, if I put my hand in pronation, and if I just flex at the elbow, we can see I'm pronated, and I put my other hand on my biceps brachii. If I move into supination, and then back to pronation and supination, I can feel that my biceps are contracting or changing shape during supination. So that now tells me that the biceps brachii are involved in performing supination at the radioulnar joints. So now we'll look at the blood supply and innervation of both the elbow and superior radioulnar joints. And considering our principle NP7, or Hilton's law essentially, is if a nerve is innervating the muscles that are acting at the joint, the nerve will also innervate the structures around that joint. So we can see here the musculocutaneous nerve innervating the anterior arm, the muscles of the anterior arm, the radial nerve innervating muscles of the posterior arm, and we also have some contribution via the median and ulnar nerves, and these are the nerves that help innervate both the elbow and superior radioulnar joint structures. Blood supply, we follow our blood supply down from the arm, and it's travelling from our brachial artery. We have our radial artery and our ulnar artery, and we can see we have recurrent branches coming from the radial and ulnar arteries, and these all anastomose around the elbow joint to assist in blood supply. So our brachial, radial and ulnar arteries all supply blood to the elbow region. For our inferior radioulnar joint, again we have innervation from our anterior, which is a branch of the median nerve, and posterior, which is a branch of the radial nerve. So anterior and posterior interosseous nerves travel down and innervate structures of the distal radioulnar joint, or inferior radioulnar joint. And our blood supply again is via the anterior and posterior interosseous arteries. Here we have two upper limb specimens, consisting mainly obviously of the skeleton. However, the model on the left will contain a couple of ligaments and a tendon. I've placed flags on a few structures, so 5 flags in all, and I'd like you to name each of these landmarks as specifically as possible, and post your answers on LMS, please. Flag A, flags B and C, and flags D and E. E may be a bit more difficult, but I'd like you to have a try, and again post your answers on LMS, please.